So today we will discuss about a very important chapter of the antimicrobial chemotherapy, that is of aminoglycosides. So aminoglycosides are a group of antibiotics that are mainly effective against the aerobic gram-negative organisms. So most of the antibiotics already we have seen, like penicillins, cephalosporins, these are mainly active against the gram-positive organisms. These aminoglycosides are mainly active against the gram-negative aerobic organisms. They are not effective against the anaerobic organisms, and in some of the cases it can have a synergistic effect on gram-positive organisms if we are adding the aminoglycosides with some gram-positive with some antibiotics that acts on the gram-positive bacteria. So let's just start with this. So these are a group of natural and semi-synthetic antibiotics having polybasic amino groups glycosidically linked to two or more amino sugar. So these aminoglycosides can be obtained naturally. They are obtained from a actinomycetes, soil actinomycetes. In the soil there is actinomycetes organism is there. From this actinomycetes aminoglycosides can be obtained. Apart from this, it can be synthesized in the laboratory. All of these contain these glycosidic links, amino sugars and polybasic amino groups. So all these comes under the aminoglycosides. So we can classify it according to their actions. So it can be used systemically or in topically. For example, systemic aminoglycosides are the most common are Streptomycin, Gentamicin, Kanamycin, Amikacin, Sisomicin, Tobramycin and Netilmicin, and topical Neomycin and pharmacology. So coming to the details about this. So what happens, these aminoglycosides are natural products of semi-synthetic derivatives of compounds produced by a variety of soil actinomycetes, what I have already told. So in the soil there is actinomycetes, from this these are synthesized. The first one is the Streptomycin. Streptomycin was the first member that was discovered in 1944 by Waxman and his colleague, and it has been shown to be active against the tubercle bacilli. So this Streptomycin is also an anti-tubercular drug. Streptomycin was first isolated from a strain of Streptomyces griseus. So Streptomyces griseus is the source, which is actinomycetes from which Streptomycin is obtained. Neomycin was the next to be isolated in 1949, but it could not be used systemically. Mainly it is used in topically. Others have been discovered later. This Gentamicin and Netilmicin, these are derived from a species of the actinomycetes known as micromonospora. So they, even if they are obtained from the natural sources, there is some difference in the actinomycetes species, and accordingly the spelling of the names of the drugs are changed. For example, you can see there are some compounds who are ending with MICIN and some compounds who are ending with MYCIN. So this difference are mainly happens. So you can see, so the difference in spelling compared with the other aminoglycoside antibiotics reflects this difference in origin. So if there is MICIN, these are obtained from the actinomycetes, which is known as the micromonospora, and the others are either synthesized semi-synthetically or obtained from the Streptomyces griseus. So accordingly the spelling change happens. Tobramycin is one of the several compounds of an aminoglycoside complex known as Nebramycin. So this is an aminoglycoside complex, Nebramycin. Within this there are different types of the aminoglycosides are there. These are obtained from the Streptomyces tenebrarius. These are also ending with the MYCIN. It is most similar in antimicrobial activity and toxicity to Gentamicin. In contrast to other aminoglycosides, Amikacin, which is basically a derivative of Kanamycin, and Netilmicin, which is a derivative of Sisomicin, these are semi-synthetic products. So at the first, when they are obtained from the soil actinomycetes, first Streptomycin and Gentamicin, these are the newer ones, and it has been seen Streptomycin is obtained from the Streptomyces species, and this Gentamicin is obtained from the micromonospora species. That's why difference in the spelling MYCIN and MICIN. But after that, it has been seen that several other soil actinomycetes are responsible for the generation of other aminoglycosides, and also synthetically they are synthesized. So accordingly, in most of the cases they are ending with the MYCIN. So aminoglycosides, you can see Streptomyces species, they are basically suffix হচ্ছে MICIN. Streptomyces species. There may be most commonly Streptomyces griseus, or this can be obtained from the other Streptomyces like Kanamycin, Tobramycin, Neomycin. These are all MYCIN. And if the source actinomycetes is the micromonospora, then the ending is the MICIN, Gentamicin, Amikacin, Netilmicin, etc. So this is very commonly asked that what is the spelling of something, like what is the spelling of the Gentamicin, what is the spelling of the Streptomycin, and what is the difference in the spelling between these two. Okay. So there are some common properties of the aminoglycosides. This is also a very common question, that what are the common properties of the aminoglycosides. So basically these are all sulfate salts which are highly soluble in water and solutions are stable for months. So highly soluble sulfate salts, they ionize in solution, that is they are polar compounds, not absorbed orally. Oral absorption is very low, oral bioavailability is very low. Mostly this has to be given either topically or by intravenous or intramuscular route. Distribute only extracellularly and do not penetrate in brain and CSF. So if there is severe septicemic conditions in the brain like meningitis, it has to be added with other antibiotics, otherwise it will not act. All are excreted unchanged in urine. That's why if there is severe infections in the urine, this can be used. All are bactericidal and more active at alkaline pH. So these are bactericidal compounds and they achieve bactericidal concentration in different body fluids when these are given, and they are more active at alkaline pH. So if we can make the body fluid alkaline, for example, if there is urinary tract infections, we are using the gentamicin. If we are alkalinizing the urine, there will be more effect of these aminoglycosides on the bacteria. Act by interfering the bacterial protein synthesis. So like the other antibiotics that acts on the bacterial protein synthesis, already we have discussed, like broad spectrum antibiotics like tetracycline, there may be some other antibiotics like chloramphenicol, etc., macrolides. This also acts by inhibiting or interfering with bacterial protein synthesis. Active against aerobic gram-negative bacteria. So this is the main target of the aminoglycosides. Aerobic gram-negative bacteria. Remember, aerobic gram-negative bacteria, they are usually not active against the anaerobic organisms, anaerobes, and very few have some activity against the gram-positive organisms. But always the spectrum differs from one antibiotic to another antibiotic. Active, they have some partial cross-resistance. So whenever we are using the aminoglycosides for all the antibiotics, already we know the resistance is gradually developing, and if resistance is developing against one type of aminoglycoside antibiotic, there will be some partial cross resistance to other type of the aminoglycoside antibiotic also. Organisms resistant to one aminoglycoside may still respond to another. Narrow margin of safety, this is very important. So margin of safety is very narrow. If it is greater than, if the concentration becomes more, there will be more chances of the adverse effects, and there are some serious adverse effects of the aminoglycosides. That is also important. All exhibit ototoxicity and nephrotoxicity. These two are the most common adverse effect of all types of the aminoglycosides. Ototoxicity, that is toxicity in the ears, both in the hearing part as well as the balance part, as well as the nephrotoxicity, that is on the kidney. The aminoglycosides are bactericidal antibiotics. Already we have seen there are main two steps by which it interferes with the bacterial protein synthesis. One is transport of the first aminoglycoside is transported within the bacterial cell wall and cytoplasmic membrane depending upon the polarity and oxygen dependent active process. So oxygen dependent active process is needed for the aminoglycosides to enter within the bacterial cell. That's why it is not active against the anaerobes. For the anaerobes there will be no oxygen, so the aminoglycoside will not enter within the cells. Binding to ribosome resulting in inhibition of the protein synthesis. How this bind? They mainly bind on the bacterial 30S ribosomal subunits. Firstly they binds and ultimately they distort the messenger RNA translocation of genetic code. So prevent the formation of the normal complex required to initiate the protein synthesis. Again the translation, there are different steps, they basically blocks the initiation and the further processes will come in. Different aminoglycosides cause misreading at different levels. So there are some minute differences in the mechanism of action between one aminoglycoside to another aminoglycosides. All they cause the misreading of the mRNA so that the protein that is formed is faulty. So ultimately that leads to degeneration of the bacterial cell. But this misreading happens at the different levels for the different aminoglycoside antibiotic. selective affinity for the specific ribosomal proteins ultimately differs from one aminoglycoside to another aminoglycoside. They also combine anionic membrane groups and damage the bacterial cell membranes. So they blocks the bacterial protein synthesis. Apart from this, they also damage the bacterial cell membrane. Proteins, amino acids ultimately leak out and also block energy production of the Krebs cycle. So energy production, ATP generation is needed for the aerobic organisms to survive. So ultimately that is also interfered with. So you can see in a nutshell the mechanism of actions. So this is the direction of the mRNA translation. Again, the different peptides are ultimately coming. The tRNA comes with the newer peptides and ultimately the peptide chain continues the elongation. So when we are using the aminoglycosides, that first blocks the initiation of the protein synthesis. So the initiation, the first peptide bonding and subsequent translocation, that is blocked. Then blocks further translation and elicits premature termination. So further translation, further adding of the peptide molecules is blocked and ultimately there may be some premature termination. So the protein that should be a 20 amino acid long ultimately terminated in 3 or 4 amino acids. That is faulty. Incorporation of the incorrect amino acid, the same thing. They are incorporating incorrect amino acids, so the mRNA, so the RNA that is formed is faulty. So ultimately, all this leads to faulty protein synthesis and bacterial degeneration. Post-antibiotic effect. So this is a typical property of the aminoglycosides, common property post-antibiotic. So even if the antibiotic concentration is not present in a sufficient amount in our plasma, there will be some effect on the bacteria. This is known as the post-antibiotic. So antibiotic level is very diminished, but there is effect on the bacteria. So this is known as the post-antibiotic effect. So mainly these effects exhibit concentration dependent killing. So with increased concentration, there will be a bulk killing of the bacteria, bactericidal. Concentration dependent killing happens with the aminoglycosides. So increased concentration can kill more bacteria at rapid rate. They also possess significant post-antibiotic effect, continue to suppress bacterial growth several hours after fall in minimum inhibitory concentration of the antibiotic. So minimum inhibitory concentration means the minimum amount of the drug that is needed to be present in our body to kill a specific minimal amount of the bacteria. So even if the drug concentration is less than the minimum inhibitory concentration in our body, when we are using very large amount of the aminoglycosides, so even after there is decrease of the aminoglycoside level, there will be post-antibiotic effect. So single daily dosing at least as effective as and no more toxic than multiple dosing. So it has been seen if we are using very high dose, just single time in a day, that ultimately becomes more effective and the adverse effects will be lesser in comparison if we are using multiple time dosing of the aminoglycosides. High dose extended interval administration of the aminoglycosides is the preferred means of administering aminoglycoside for most indications and patient populations. So what happens, aminoglycosides previously used very commonly, but it has been seen the adverse effects are also very large. Usually the aminoglycosides, the half-life is lesser, so previously it was used usually 3 or 4 times a day. And when it is used 3 or 4 times a day, there will be more chances of the aminoglycoside concentration more than the minimum inhibitory concentration, but also there is more chances that it will be higher than the toxic concentration. So it has been seen to be toxic to the individuals. But later different trials have been done and it has been seen if we are using very high doses but just once in a day, that ultimately leads to less exposure of the drug to the body and ultimately the toxicity will be very less. So extended interval once daily dosing of the aminoglycosides is now commonly used. Antibacterial spectrum, aerobic gram-negative bacteria, already we have seen. Example, Citrobacter, Enterobacter, E. coli, Proteus, Shigella, Pseudomonas, all are very much susceptible to the aminoglycoside antibiotics. Apart from this, Enterococci and Staph aureus, which are gram-positive organisms, they are also to some extent are susceptible to aminoglycosides. Streptomycin and Kanamycin, these are active against the Mycobacterium tuberculosis, while Amikacin, Gentamicin and Tobramycin are active against Streptococcus faecalis and Pseudomonas aeruginosa. So there will be some more spectrum of these antibiotics. Not effective against the gram-positive bacilli. gram-negative cocci and anaerobes. They are not effective. Gram-positive bacilli, gram-negative cocci and anaerobes, they are not effective. They are not effective against the anaerobes because the penetration of the aminoglycosides across the porine channels within the bacteria depend upon this polarized membrane and oxygen dependent active process, since lack of oxygen make them inactive against the anaerobes. Already we have discussed. So they are mainly effective against some gram-negative aerobic bacteria like these ones, and to some extent some gram-positive bacteria like Enterococci, Staph aureus. They are not effective against the gram-positive bacilli, gram-negative cocci and anaerobic organisms. Facultative anaerobes are resistant in oxygen supply is deficient. Facultative means if there are some obligate anaerobes and there may be some facultative anaerobes. So facultative anaerobes can generate more with oxygen dependent process as well as the oxygen independent process, but it has been seen even if facultative anaerobes may be resistant to the aminoglycoside antibiotics. So oxygen is very much beneficial. Presence of the oxygen within the cell is needed for the aminoglycosides to act. Resistance may be plasmid mediated, development of the resistance may be plasmid mediated, and inactivation by microbial enzymes. Failure of the drug mediation may also happen due to mutation of the porine channels. So decrease in the aminoglycoside transport mechanism may happen. Synthesis of the some metabolizing enzymes. So these enzymes will metabolize the aminoglycosides before they act. More metabolism. This may happen due to acetylation, phosphorylation and adenylation. This can be happen due to presence of these enzymes like acetyl transferase, phosphotransferase and adenyl transferase. So these enzymes will be uplifted, these enzymes will be more expressed, and these enzymes ultimately causes more metabolism of the aminoglycosides if we are using the aminoglycosides for long period of time in an individual. Mutation may alter ribosomal binding site for the aminoglycosides. So prevents binding to 30S. So the binding, where after binding there will be some premature termination of the protein chain synthesis, there will be some initiation blockage, there may be miscoding, so all this can be prevented if they are ultimately changing the site where the aminoglycoside have to bind. Cross resistance is observed, already we have seen. Pharmacokinetics absorption, it is highly ionized, it is a polar molecule, already we have seen, not absorbed or destroyed by the gastrointestinal tract, that's why it usually not can be given by the oral route. Intramuscular, if we are giving intramuscular injections, there will be rapid absorption. Plasma peak concentration usually achieved within 30 to 60 minutes. Extracellularly, it is distributed 20 to 30%. High concentration is achieved in endolymph and renal cortex. That's why there will be some adverse effects with this aminoglycosides. So when we are using the aminoglycosides, there are high concentration achieved within the endolymphatic fluids as well as the renal cortex. Do not cross the blood-brain barrier, already you have seen. May some cross placenta, they get distributed in serous fluids like synovial, pleural, peritoneal, etc. So if there is some pleuritis, peritonitis, or if there is some synovial fluid irritation, so in all these cases we can use this because they are entering within the serous fluids. Excreted unchanged in urine, main channel of excretion is glomerular filtration, plasma TF is 2 to 4 hours. So that is the difference. Even if the plasma half-life is very less for all the aminoglycosides, we have seen that if we are using some extended interval usage of this aminoglycoside like just once daily dosing with very high concentration, the adverse effects will be less. In elderly people and neonates, the drug dosing should be low as they have low glomerular filtration rate because there is always chances of the nephrotoxicity. Renal clearance of the aminoglycoside parallels the creatinine level. So if we have to measure the creatinine level frequently when we are using the aminoglycosides to see if there is any renal compromise or not. Now coming to the shared toxicity, common toxicities of all the aminoglycosides. First one is the ototoxicity. Already we have seen that when the aminoglycoside is given, that achieves a very high concentration within the endolymphs, within the ear. This is the most important dose and duration of treatment related adverse effect. So dose and duration. So if we are using it for a long period of time, there is more chances of the ototoxicity. The vestibular or the cochlear part may be primarily affected by a particular aminoglycoside. So some aminoglycoside may affect more the vestibular part, some may affect more the cochlear part. These drugs are concentrated in the labyrinthine fluids and are slowly removed from it when the plasma concentration falls. So even if the plasma concentration falls, even if there is no antibiotic, so even if there will be very more time is needed for all the drugs to remove from the endolymphatic fluid and labyrinthine fluid. The vestibular and cochlear sensory cells and hairs undergo concentration dependent destructive changes. That is the problem. So when there is very high aminoglycoside concentration within this endolymphatic fluid, there will be some destructive changes in the sensory cells, cochlear sensory cells, vestibular sensory cells, the sensory hairs. All these are needed for the maintenance of the balance as well as the hearing. All these can be compromised. Cochlear damage usually starts from the base. So cochlear base are first affected and then spreads to the apex. That's why the hearing loss affects the high frequency sounds first. So high frequency sounds are usually achieved due to the vibration of the cochlear base. Since the base of the cochlea are firstly affected when we are using the aminoglycosides, that's why high frequencies hearing loss usually happens when we are using the aminoglycosides first and then progressively encompass the lower frequencies. So ultimately if we are continuing this high dose of the drugs for a long period of time, then the low frequency sounds hearing is also affected. Vestibular damage, if there is damage to the vestibular apparatus, that mainly controls our balance. So there will be headache is usually first to appear, followed by nausea, vomiting, dizziness, nystagmus, vertigo and ataxia. So ataxic gait, so the patient cannot walk in a straight line. There will be vertigo. So there will be always, if the patient is always, there is chances of the fall. Nystagmus, there is the eyeball will be rolling from one side to another side. All this can happen due to the change in the balance. Then coming to the nephrotoxicity. So first is the ototoxicity. Ototoxicity, under ototoxicity, both the cochlear toxicity and vestibular toxicity, two types. And then coming to the nephrotoxicity. Again, it mainly concentrates high in the renal cortex. It is mainly excreted through the glomerular filtration. So ultimately tubular damage resulting in loss of the urinary concentrating power, low glomerular filtration rate, nitrogen retention, albuminuria and different types of the cast, most commonly granular cast or hyaline cast can develop. Aminoglycosides attain high concentration in renal cortex and toxicity is related to the total amount of the drug received by the patient. All this total amount of the drug for a long period of time ultimately is determinant for the nephrotoxicity. It is more in elderly and in those with pre-existing kidney disease. So if there is elderly, the glomerular filtration rate is already less. If there is pre-existing kidney disease, already the renal compromise is there. However, this kidney damage is reversible if drug is discontinued. So it can be reversible. Next, coming to the neuromuscular blockade of the aminoglycosides. All aminoglycosides ultimately reduce the acetylcholine release from the motor nerve endings. So you know that from the motor nerve endings, acetylcholine is needed. Acetylcholine is released, which is the neurotransmitter for the generation of the different motor activity. So when we are using these aminoglycosides, they reduce this acetylcholine release from the motor nerve terminals. So ultimately all this leads to Curare-like action. So you can remember the muscle relaxants. So muscle relaxants, Curare is a muscle relaxant. So Curare-like muscle relaxants are there. Particularly all these decrease the acetylcholine release. So muscle activity, muscle becomes more relaxed. So that can happen and this is known as the neuromuscular blockade. If there is more neuromuscular blockade, so there may be paralysis. And if there is respiratory muscles become neuromuscular blockade, so there may be respiratory arrest. The patient cannot take breath. So this can also happen. They may cause apnea on IV injection. Apnea means temporary stoppage of the respiration. When we are using the IV injection, again there will be sudden decrease of the acetylcholine release from the motor nerve terminals and Curare-like action, like the South American tribes. They are using the arrow poison like Curare that ultimately hits instantly. There will be decrease of the acetylcholine and the patient may die or patient may go into the paralysis. That may again happens with this aminoglycosides. The blockade, if severe, can be effectively treated by neostigmine. So neostigmine is just the we can say the antidote if there is some neuromuscular blockade poisoning happens. Again the neostigmine can be used here also. So we are using some aminoglycosides, there will be some neuromuscular blockade. So we can use the neostigmine to reverse the actions of this neuromuscular blockade. Okay. So there are some precautions and interactions of these aminoglycosides. like avoid during pregnancy, because again the fetal ototoxicity may be there, because within the fetus they enter and again there may be some vestibular or cochlear toxicity in the fetus. So it should be avoided during pregnancy. Avoid concurrent use of other ototoxic drugs. So there are some other drugs like ototoxic, like high ceiling diuretics. So if we are using very high dose of the furosemide, that is also ototoxic. So this should not be combined. Minocycline is another ototoxic drug. Avoid concurrent use of the other nephrotoxic drugs also. For example, amphotericin B, you will read in the antifungal chapter, that is also an important drug for the Kala-Jar. So amphotericin B is very much nephrotoxic. Vancomycin, already you have read, vancomycin is a mainly acts on the gram-positive bacteria. It is a nephrotoxic drug. Cephalothine is a cephalosporin antibiotics, and cyclosporin is a immunosuppressive. These all are the nephrotoxic drugs. So again, this should not be combined, or we should, even if it is needed, we should be cautious. Cautious use in patients past middle age and these with kidney damage. So when we are using the aminoglycoside, first we have to see what is the glomerular filtration rate and the creatinine level of the patient. If it is less, so aminoglycoside should be avoided. Cautious use with muscle relaxants. Again, the muscle relaxants may be needed for the short operations. For example, we have to do some tube, we have to do some tracheostomy, or we have to do some laryngoscopy. So we are using some muscle relaxant. Again, this aminoglycoside can cause the neuromuscular blockade. So together, if these two are combined, there may be severe neuromuscular blockade and respiratory arrest can happen. So we should be cautious about this. Do not mix aminoglycosides with any drug in some syringe or infusion bottle. So it should be given as a stand-alone antibiotic. It should not be mixed with some saline bottles or other antibiotics, because there may be more drug-drug interactions. Now coming to the dosing regimens. So already we have seen, first, aminoglycoside is a very low safety margin drug, narrow margin of safety. So there may be, when we are using this, there will be slight increase of the aminoglycosides. There may be some toxicity. The most toxicity happens in the ototoxicity and nephrotoxicity. But again, aminoglycoside is a very short half-life drug. So we have to use previously repeated times. But when we are using the repeated times usage of the aminoglycosides, there will be always chances of the toxicity more. So because of the low safety margin and the daily dose of systemically administered aminoglycoside must be precisely calculated according to the body weight and level of renal function. So what will be the body weight? What is the creatinine level, glomerular filtration level? Accordingly, the total dose of the aminoglycosides is to be fixed. For an average adult with normal renal function, normal means the creatinine clearance is greater than 70 milliliter per minute. The usual doses are, for example, for Gentamicin or Tobramycin, Sisomicin or Netilmicin, 3 to 5 milligram per kg per day. So usually, and for Streptomycin, Kanamycin or Amikacin, 7.5 to 15 milligram per kg per day, because these are the low potency drugs, these are the high potency drugs. That's why more doses are needed here. So this is a basic dictum, but after that we have to increase if it is not controlled. So considering the short T-half 2 to 4 hours of aminoglycosides, the daily doses are conventionally divided previously into 3 equal parts and injected either intramuscularly or intravenously slowly over 60 minutes every 8 hours. Previously it was used. So you can see, when we are using the 3 times daily dosing, so this green one is the toxicity threshold. So we have to keep the, if the drug concentration becomes more than this for a prolonged period of time, there will be more chances of the toxicity. So you can see, because of the short T-half, it is usually customary to use this usually 3 times a day. When we are using the 3 times a day, so first we are giving, so again it will be decreased, again we are giving the drug, again it will be decreased, again we are giving the drug, it will be decreased. So in most of the cases, this will be above the toxicity profile. So you can see. But when we are using very high dose, but once in a day, for example, this red one, they are very high dose. You can see this is the dose, this is the stain, and this is very high dose, 30. So ultimately, we are using just once daily. So it gradually decreases and gradually it comes under the toxicity profile, and it has been calculated to see that when we are using this, the chances of this above this is very much less in comparison when we are using it thrice daily. So this is known as the extended interval once daily dosing of the aminoglycoside. So this is an example that even if the drug half-life is very less, 2 to 4 hours. So when we are saying that the drug half-life is 2 to 4 hours, usually drug have to be given minimum twice daily or thrice daily. So why the aminoglycoside, even if the half-life is very less, usually it is customary to give very high dose but single dose. This is the reason. So because of the toxicity. So this is the graph. If we can understand the graph, so it will be clear. So you can see in most of the cases it will be lower than this, but here in most of the cases it will be higher than this green line. So that's why the aminoglycosides are given once daily, but the total daily dose is the same. So this high dose is given once. Ultimately, if we can adding these doses 3, so you can see 10 plus 10 plus 10. So ultimately 30. So we are giving just once 30. So this is that's why how the dosing of the aminoglycosides is done. Now coming to the streptomycin. Streptomycin is the first aminoglycoside antibiotic and it has also been shown to have anti-tubercular activity. That is very important. So it is older antibiotics obtained from the Streptomyces griseus used in past exclusively, but now used only for the treatment of the tuberculosis. Because again, most of the tuberculous bacteria becomes resistant. So you know that there is multi-drug resistant tuberculosis is also coming. That's why some drugs are reserved to only use for the tuberculosis, not for the other infections. The antibacterial spectrum is relatively narrow, sensitive to Haemophilus ducreyi, Brucella, Yersinia pestis, tularensis, Nocardia, tuberculosis, E. coli, Klebsiella, Enterococcus, Shigella, etc. Resistance may develop. Streptomycin dependence can also develop. So certain mutants become dependent on streptomycin as they promote mutant growth. So this occurs when the antibiotic induced misreading of the genetic code becomes a normal feature of the organism, mainly occurs in the tuberculosis. So again, when we are using this in the tuberculosis, the tubercle bacilli becomes resistant to it, and a particular type of resistance is the streptomycin dependence. So ultimately the mutant strain that is ultimately becomes the normal feature of the bacteria. That's why. Indications, mainly it is used in tuberculosis. Apart from this, this is used in some rare disease like tularemia, subacute bacterial endocarditis and plague. In these cases, the streptomycin can be used. So already you have seen about the aminoglycosides, more or less similar, like neither absorbed nor destroyed in the gastrointestinal tract. Absorption from the injection site in muscle is rapid, distributed extracellularly, volume of distribution 0.3 liter per kg, attains low concentration in synovial and pleural fluid. It is not metabolized, excreted unchanged in urine. Plasma half-life is more or less similar, 2 to 4 hours. Adverse effects, same, vestibular disturbance, auditory disturbance, nephrotoxicity. There may be some hypersensitivity reactions, pain at injection site, paresthesia, scotoma, etc. Next, coming to the gentamicin. Gentamicin is another older aminoglycoside antibiotic that is obtained from the Micromonospora purpura in 1964, and since this is obtained from the Micromonospora, that's why MICIN, and has become most common antibiotic in acute infections. Previously it is indiscriminately used. Plasma half-life is 2 to 4 hours after intramuscular injections, but it has some differences from the streptomycin, like it is more potent in comparison to the streptomycin. It has broader spectrum of activity. It is effective against Pseudomonas aeruginosa and most strains of the Proteus, E. coli, Klebsiella, Enterobacter and Serratia. These organisms are very notorious for the development of the gram-negative septicemia. So gram-negative septicemia due to Pseudomonas. You can see these are becomes resistant to several types of the drugs. So in most of the cases, we can use the aminoglycoside antibiotics if there is some Pseudomonas infections, Shigella infection, E. coli infection, Serratia infection, like this. It is not effective against the Mycobacterium tuberculosis. So only the Streptomycin and Amikacin and Kanamycin, these three are effective against the Mycobacterium tuberculosis. Streptopycin is not effective. Streptopneumonia and some Staphorias, it is more nephrotoxic. That's why it is lesser used nowadays. Gentamicin use is restricted to serious gram-negative bacterial infections. What I am talking. So septicemia, severe septicemia from some, for example, from the urinary tract infections, the causative organism is the Pseudomonas or the Shigella. In these cases, we can use the aminoglycoside like gentamicin. Very valuable for preventing and treating respiratory infections in critically ill patients, in those with impaired host defense. like anti-cancer drug, corticosteroid, aids or neutropenic. So the patient is already immunocompromised. The patient, for example, in the ventilator or in the ICU, and there is severe gram-negative septicemia, so and respiratory infections, we can use the gentamicin. Septicemia, sepsis, fever in immunocompromised patients, it usually used in combination with the penicillins or cephalosporins. Subacute bacterial endocarditis, which is a grave disease, we can use these aminoglycosides with combination of the penicillins or ampicillin or vancomycin. So there are some regimes of the endocarditis treatment where usually aminoglycosides is added with some cell gram-positive cell wall active agent. Pseudomonas, Proteus, Klebsiella infections. These infections are very notorious. This can be happen in the burns, urinary tract infection, pneumonia, lung abscess, osteomyelitis, middle ear infection, septicemia. So we can use the aminoglycoside. In most of the cases, we have to use some combinations of aminoglycoside with some antibiotics. Meningitis by gram-negative bacilli, in some of the cases it may be active. Topical, it can be used in infected burns, wounds, skin lesions with purulent exudates, etc. Kanamycin is obtained from the Streptomyces kanamycetes, similar to Streptomycin and active against the Mycobacterium tuberculosis, but lack activity on the Pseudomonas. It is very much toxic to the cochlea and kidney. Hearing loss is irreversible. So once it happens, it cannot be reversed back. Because of the toxicity and narrow spectrum, it is replaced by other drugs. But it is very part and parcel of the treatment of the multi-drug resistant tuberculosis. So kanamycin is very commonly used as a regime in MDR-TB, multi-drug resistant tuberculosis. Tobramycin, it is identical to gentamicin obtained from the Streptomyces tenebrarius, used in Pseudomonas and Proteus infection. Ototoxicity and nephrotoxicity are somewhat lesser than the other ones. Amikacin is very commonly used now, less toxic semi-synthetic derivative of the kanamycin, but more hearing loss occurs if it is used for a long period of time in very high concentration. Resistant to enzymes that inactivate gentamicin and tobramycin. That's why even if the bacteria becomes resistant to gentamicin and tobramycin, we can use the amikacin. Wider spectrum of activity, so they can affect different types of the bacteria. Uses more or less similar to gentamicin. Mainly it is a reserve drug for hospital acquired gram-negative bacillary infections. So hospital acquired, the patient have already admitted and there will be some hospital acquired gram-negative infection or septicemia, we can use. Again, it can be used in multi-drug resistant tuberculosis resistant to streptomycin along with other drugs. So amikacin have broadest spectrum of activity, mostly in different types of the gram-negative organisms. Sisomicin is identical to gentamicin, equal in toxicities more or less, more potent on Pseudomonas and beta hemolytic streptococci and obtained from the Micromonospora inionensis. Since it is again obtained from the Micromonospora, that's why MICIN. Netilmicin is again, it is a derivative of the Sisomicin. It is resistant to many enzymes that inactivate the gentamicin and tobramycin. So additional ethyl group protects from enzymatic degradation. These have the lowest toxicity among all the aminoglycosides. This Netilmicin, more active against the Klebsiella, Enterobacter and Staphylococci, less active against the Pseudomonas. Doses and pharmacokinetics are more or less similar to gentamicin. So these are the newer semi-synthetic aminoglycosides. This is semi-synthetic Netilmicin. That's a lesser toxicity. That's the difference. Neomycin is another important aminoglycosides that is used slightly different ways. It has a wide spectrum, active against gram-negative bacilli and some gram-positive cocci and obtained from the Streptomyces fridii. Pseudomonas and Streptococcus pyogenes are not sensitive. You can see Pseudomonas are not sensitive, Streptopyogenes are not sensitive. It is too toxic for parenteral use. That's why it cannot be given by intravenous or intramuscular route. Mainly it is used as a topical agent. Topically it can be used. It can be used topically in skin, eye and external ear infections. It can be combined with bacitracin or polymyxin B to widen its antibacterial spectrum and prevent emergence of the resistant strains. So usually it is used topically in skin infections or eye infections as a drop or external ear infections. It can be used. Apart from this, it can be used orally. So neomycin only have very few aminoglycosides that can be used orally, but only for the preparation of the bowel before surgery. So there will be sterilization of the bowel before surgery. And next is if there is hepatic encephalopathy or hepatic coma. So when there is hepatic encephalopathy or hepatic coma, we are using this neomycin that mainly suppress the ammonia forming coliforms, and ultimately that prevents the encephalopathy. Usually the lactulose is preferred. Already in the gastrointestinal pharmacology chapter you have read about the lactulose. So lactulose is used in hepatic encephalopathy, very common questions. So after the lactulose, another thing that is used in hepatic encephalopathy is the neomycin. So mechanism is similar. When we are using the oral neomycin, that causes sterilization of gut, that mainly suppress the ammonia forming coliforms, because when there is hepatic coma or hepatic compromise, there will be more ammonia generation from these ammonia forming coliforms. So when in case of the hepatic encephalopathy, if we are using this first lactulose, if it is not responding, we can use the neomycin. There will be lesser chances of the hepatic problems to go into the hepatic encephalopathy. Bladder irrigation along with polymyxin B, again this can be done before surgery, before bladder surgery can be done. So remember, neomycin is a drug, only aminoglycoside drug that can be used orally. Mainly it is used as a preparation of the bowel before surgery and in hepatic encephalopathy, and also in case of the bladder irrigation. Pharmacockinetic. Pharmacockinetic is obtained from the Streptomycin lavandulae. Similar to the neomycin, it is toxic for systemic administration, used topically on the eye, skin and ear. So you have heard about the Streptomycin cream. In some of the house there may be Streptomycin. So this is basically pharmacockinetic. So this is mainly used topically. So if there is some topical infections, so we can use the skin infections. So we can use the pharmacockinetic. Tobramycin is another drug that its properties are similar to that of the neomycin. It has pronounced activity against many protozoan parasites in addition to the bacteria. For example, they are active against Entamoeba histolytica. So they Giardia lamblia, Trichomonas vaginalis. So this Tobramycin, even if it is an aminoglycoside antibiotic, this can also be termed as an antiprotozoal antimicrobial agent, because these are active against the Entamoeba histolytica, Giardia lamblia and Trichomonas vaginalis, Cryptosporidium and also Leishmania donomani, that causes the kalajor. In addition to many bacteria sensitive to neomycin. So Tobramycin is an antiprotozoal drug in addition to its aminoglycoside properties. Mainly it is used in intestinal infections. Again it is also used, Tobramycin is similar to the neomycin. So again it can be used in hepatic encephalopathy. Treatment of the amoebiasis, when you read about the amoebiasis, you will see that Tobramycin is a drug that is used as an amicidal agent. And parental in visceral leishmaniasis, means when the kalajor becomes active, affects the different visceral organs, this is known as the visceral leishmaniasis. In these cases we can also use the Tobramycin. So this Tobramycin and neomycin are somewhat different from the other aminoglycoside antibiotics, neomycin and Tobramycin. Remember this. So lastly, aminoglycoside uses, already we have discussed. So this is in a nutshell. So aminoglycosides frequently used in combination with cell wall active agent. Usually in very less of the cases we are using only aminoglycosides, because aminoglycosides are mainly used in gram-negative infections, severe infections like septicemia. So the patient is already admitted and there is septicemia. So we have to give the cover for the gram-positive organisms also. So we have to give the aminoglycosides as well as other cell wall active agent like beta-lactams or some glycopeptide antibiotic like vancomycin for the therapy of the serious proven or suspected bacterial infections. And aminoglycosides, since it is bactericidal agent and it has concentration dependent activity, so with increased concentration, if there is severe septicemia, we can control it. The rationale is we can expand the empiric spectrum of the activity of the antimicrobial regimen. So when we are adding some penicillins or glycopeptides with some aminoglycosides, we are basically exploring and expanding the antimicrobial spectrum, because this patient, since it is admitted, there will be broad spectrum of the infections to provide synergistic bacterial killing. So already it has been seen that even aminoglycoside, if it is added, there will be synergism, that is 1 + 1 greater than 2, more bacteria will be killed to prevent the emergence of the resistance to the individual agents. So when we are using only the aminoglycosides, there will be thriving of the other bacteria that are not affected by the aminoglycosides. So there will be more chances of the resistant formation. That's why combination is needed. Combination therapy is used in infections such as healthcare associated pneumonia, hospital acquired pneumonia, very common cause of the morbidity and mortality, sepsis or septicemia, where multi-drug resistant gram-negative organisms like Pseudomonas aeruginosa, Enterobacter, Klebsiella, Serratia may be causative. So now in the ICU, whenever you go to the ICU or on some patients who are on the ventilator, there are severe respiratory infections or severe urinary tract infections that become septicemia. If their blood culture is done, you will see in most of the cases the organism is either Klebsiella, either Pseudomonas, or either E. coli, or either Serratia like this. And in most of the cases now we are seeing some multi-drug resistant Klebsiella, multi-drug resistant Pseudomonas like this. So in these cases we can control with judicious use of the aminoglycoside antibiotic. Use of the aminoglycosides to achieve the synergistic bacterial killing and improve clinical response is most well established for treatment of the endocarditis also due to gram-positive organism, most importantly the Enterococcus. So endocarditis, so endocardium is affected, heart endocardium. So the treatment is very complex. Here the aminoglycoside plays a very crucial part in combination with the other agents for tackling the endocarditis. Urinary tract infections. Although the spectrum of activity and concentration in the urinary tract of the aminoglycosides make them well suited for the treatment of the UTI, less toxic alternatives are preferred for uncomplicated infections. So remember always that aminoglycosides are mainly used in complicated infections, hospital admitted infections. So if there is some uncomplicated UTI, even if they achieve very high concentration in the urinary bladder, this should not be used. Strains of the E. coli have acquired resistance to beta-lactams, trimethoprim, sulfamethoxazole, fluoroquinolones. So there are some resistant, multi-drug resistant E. coli. Here we can use the aminoglycosides. A single intramuscular dose of the gentamicin has been effective in uncomplicated infections of the lower urinary tract where the E. coli is resistant to other antibiotics. A 10 to 14 days course of the gentamicin or tobramycin is an alternative for treatment of the pyelonephritis. So the tubules becomes affected, tubules of the kidney. So pyelonephritis, this is also a grave disease where we need a 10 to 14 days use of the aminoglycosides. Pneumonia, already we have discussed. Severe pneumonia or hospital acquired pneumonia, patient is already admitted, or in the ventilator, community acquired pneumonia. They mainly respond if we are combining with the aminoglycoside with some cell wall active agents. Aminoglycosides are ineffective for the treatment of pneumonia due to anaerobes. Already we have seen they are not active against the anaerobes, or streptomycin, which are common cause of the community acquired pneumonia. In hospital acquired pneumonia, where aerobic multi-drug resistant gram-negative bacilli are frequently causative pathogen, an aminoglycoside with beta-lactam antibiotic is recommended as a standard empiric therapy to increase the likelihood that at least one agent is active against the infective pathogen. So what happens when the pneumonia is the community acquired? In most of the cases, aminoglycoside is not effective because the community acquired pneumonia are mainly caused by the streptomycin, and the aminoglycosides are cannot kill the streptomycin in most of the cases. But in hospital acquired pneumonia, which is a very common in our country also, usually it has been seen if we are adding the aminoglycosides with some penicillin, cephalosporins or glycopeptides, that ultimately gives a very good regime for the tackling. Peritonitis, already we have seen in peritoneal fluid they achieve a high concentration. So we can use intravenous or intramuscular injections. Bacterial endocarditis, already we have seen synergistic or low dose gentamicin with a penicillin or vancomycin is very effective in bacterial endocarditis. So remember the indications: peritonitis, bacterial endocarditis. These are the infections that are very difficult to treat. In these cases, usually the aminoglycosides are used. Penicillin and gentamicin in combination are effective as a short course, 2 weeks, regime for uncomplicated native valve streptococcal endocarditis. So there are different types of the endocarditis. So if the valve is replaced, so there may be some native valve endocarditis or there is some metallic valve endocarditis. So we can use the penicillin gentamicin combinations in uncomplicated native valve streptococcal endocarditis. But if there is enterococcal endocarditis, concomitant administration of the penicillin gentamicin for a long period of time, for example 4 to 6 weeks, is needed as a standard therapy. So endocarditis that is caused due to some enterococcus. So enterococcus endocarditis, very severe disease. Here we have to use the combinations of the penicillin as well as the aminoglycosides for a long period of time, approximately 1.5 months to 2 months. A 2-week regime of the gentamicin in combination with napsilin is effective for the treatment of selected cases of the staphylococcal tricuspid native valve endocarditis. So this is the Enterococcus infections, this is the Streptococcus infection, this is the Staphylococcus infection. So the endocarditis may happen due to the different types of the bacteria, gram-positive bacteria, and accordingly the regime of the aminoglycosides with other penicillins or the glycopeptides will be different. For native mitral or aortic valve staphylococcal endocarditis, the risks of the aminoglycoside administration likely outweigh the benefits. So that means in endocarditis, a long period of the time is needed for the aminoglycoside treatment, and already we have seen there will be toxicity when we are using for a long period of time. But even if we can weigh the balance between the pros and the cons of the using the aminoglycosides, since the endocarditis ultimately gives us a very high mortality. So even if there may be some compromise in the adverse effects of the aminoglycosides in terms of the ototoxicity and nephrotoxicity, so we should use the aminoglycosides, because if we are not using the aminoglycoside, the patient can die. That's why. Sepsis, septicemia due to the gram-negative organisms. Already we have discussed multiple times that this is the drug of the choice, aminoglycosides that can be added with different other antibiotic agents. So this is more or less similar, same thing. Tularemia, plague and mycobacterial infections, already you have seen these are some rare infections, tularemia, where streptomycin is the drug of choice for the treatment. Most cases respond to the administration of 1 to 2 gram of streptomycin per day for 10 to 14 days. Plague, 10-day treatment course of streptomycin or gentamicin is recommended for the severe forms of the plague. So there are different types of the plague already we have seen in the microbiology, like bubonic plague, etc. Ultimately, if we can control with these aminoglycosides, that ultimately will not lead to the cerebral compromise. Mycobacterial infections, time and again we have seen there are 3 aminoglycoside antibiotics, streptomycin, kanamycin, and mostly the amikacin. These 3 are mostly used in the treatment of the Mycobacterium tuberculosis. Cystic fibrosis. Cystic fibrosis is a lung disease. This happens due to the mutation in the CFTR gene. So there will be changes in the chlorine channel, and there will be some atelectasis of the alveoli, and there will be problems of the severe infections with pseudomonas. Here we can use the aminoglycosides that frequently used to decrease the exacerbations, acute exacerbations of dyspnea that may happen to cystic fibrosis, and higher than standard doses are frequently employed. So very high dose, you can see 10 milligram per kg of the Tobramycin is used when we are treating the cystic fibrosis patients. Topical applications, already you have seen that neomycin, paramomycin, this can be used topically, may be employed as topical agent in skin and mucous membrane infection. Apart from this, pharmacology is a very commonly used topical agent. Oral administration of the aminoglycosides may be employed as a bowel preparation, already you have seen, or a selective digestive decontamination. So this is mainly used in the hepatic encephalopathy to reduce the risks of ventilator associated pneumonia also. So thank you. This is all about the aminoglycosides. So within the aminoglycosides, again I am saying the important part. Very important questions is the common properties of the aminoglycosides. Very important questions. So you have to write everything. What are the common properties? What are the common adverse effects of the aminoglycosides? Ototoxicity and nephrotoxicity frequently are asked in the theory as well as the viva. Within the individual agents where the aminoglycosides are mainly used, and the short note can come with the streptomycin, gentamicin. These 2 are the previous ones are the most commonly used, and again the specific where the neomycin can be used or paramomycin can be used, how it is used in the hepatic encephalopathy, etc.